Yeah, dear students, welcome back to the medical visualization lecture and to virtual endoscopy. We discussed in the last video lecture what virtual endoscopy is, strongly inspired by real endoscopy. One tries to investigate air-filled or fluid-filled structures like the colon or the bronchial tree. Navigation is quite important. We are inside such elongated, strongly curved or even branching structures. So therefore, virtual endoscopic views really provide additional information that you could not easily infer from just looking at the slices of CT data. Yeah? This different way of presenting the information reveals abnormalities on vessel walls or on colon walls, for example, that are much more difficult to see otherwise. We discussed last week, the approaches to virtual endoscopy, segmentation, skeletonization, path planning. We also discussed why this is useful, what it can be used for. We discussed briefly some applications without a lot of detail. And the last thing that we did was indeed to think about the visualization techniques that are useful for virtual endoscopy. Real-time performance here is crucial. The user could not tolerate to wait several seconds or even fractions of seconds where nothing happens. On the one hand, on the other hand, good spatial relations are important. So therefore, not only simple surface and volume rendering techniques are applied, but also illumination effects, including ambient occlusion, shadow projection are important. We discussed already the general limitations. Of course, in virtual endoscopy, we have no true colors that we could observe with a real camera inside the human body. We also cannot have tactile sensations. It's just a visual exploration of the human anatomy. And thus we probably cannot detect inflammation, which often is quite important. But we can see changes of walls, and that relates, for example, to polyps in the colon that are often benign predecessors of a later colon cancer. And by removing these polyps, we can avoid this. Yeah, that is to briefly recap from the last video lecture. What you can expect today, we discuss applications, and by thinking about applications, we have to assess virtual endoscopy from 2 points of view. One is a little bit more from a technical point of view. That is what I would refer to as validation. How correct are the visualizations that we see in endoscopic views? Or one could also say how much can we rely on what we see there? Yeah? If there is a certain change in a wall, is this really something that's inside the patient's body, or is this an artifact from CT imaging or from image processing? So that's validation. Imagine for a moment that it turns out there are few artifacts and they are not so extended. So basically the results from virtual endoscopy are usable. Then the question is, of course, are they also useful? Yeah? Do they provide additional information for a clinician? Do they provide clinically relevant information that may be useful for a therapy decision? Yeah? So that is what is called the evaluation. The evaluation is more about the usefulness, yeah, and we will think about this also. I will start with showing this image from the book on virtual endoscopy and related 3D techniques that I have used already several times. A book that appeared already in 2001, so that was really pioneering work to summarize the early developments and the potential of virtual endoscopy. Yeah, you see the endoscopic view again with some lightning effects. You see an external 3D view, and you see the slices, and you also see the path here that was computed so that this becomes visible as well. So this combined visualization often is very useful. Comprehensive studies, I mentioned this briefly in the last video lecture, showed that in particular virtual colonoscopy has a similar diagnostic performance than optical colonoscopy for detecting clinically relevant polyps. And these are not the smallest ones, but those that are beyond 10 millimeter. Not all studies indeed showed such a favorable result for virtual colonoscopy. There are also studies that show that optical colonoscopy is significantly superior to virtual colonoscopy. But these studies are not very good. For two reasons. Either the imaging that was used was not really of high quality in terms of slice distance, in-plane resolution, and signal-to-noise ratio. And the second thing is also quite important. Like with real endoscopy, also with virtual endoscopy, you need physicians that are experienced. Yeah, you know this logarithmic learning curve that you often have. If you have persons that are on the lower part of their learning curve, then they may get bad results with virtual endoscopy. They may miss polyps, although they are quite clearly visible there, or they may misinterpret something as a polyp that is indeed smaller and probably an artifact. So Karen Horton in her summary wrote, "It is easier to get bad results with inexperienced radiologists and bad technology." Yeah? When experienced physicians were employed and the quality of the CT data fulfills some requirements that could be considered as minimal, then indeed it was possible to achieve similar results in terms of sensitivity and specificity of polon detection. And based on these favorable outcomes, virtual colonoscopy is reimbursed by the insurance companies in the US since 2005. Yeah, they would only reimburse this, that means they pay for this, yeah, if it is proven that this is a useful thing. And of course, the promise was, and indeed is still, that more people use the opportunities of screening that is provided by virtual colonoscopy compared to real colonoscopy with a certain risk for complications, even severe complications, and also which is less comfortable. Yeah? That all was summarized in a study by Perry, Picard and colleagues. Yeah, that was to say a few words on virtual colonoscopy. Let me make a few remarks also on virtual bronchoscopy, and again, instead of commenting on a certain individual publication or a small selection of them, I refer to a review article, a kind of survey article that summarizes how virtual bronchoscopy is actually used in clinical practice. That means in particular for which type of diagnostic and therapeutic questions it is used. So one first statement is that virtual bronchoscopy typically uses surface rendering as major rendering mode. The bronchial tree as an air-filled structure is easy to distinguish from other structures in a thorax CT dataset. However, there is of course a certain partial volume effect, yeah, that is this kind of averaging over the area of the volume of a certain structure. And therefore, if you want to see smaller parts of the bronchial tree, bronchial segments in the periphery, these would form only a small portion of a voxel, or at least not the full voxel, and therefore you need a different threshold to segment them, to see them. Yeah? So often the isosurface rendering is a combination of two thresholds, minus 800 for the central bronchial segments and minus 400 for the smaller segments in the periphery. Yeah? Air has approximately minus 1000 Hounsfield units, so that is the smallest value that you can have with the Hounsfield scale, the central parts of the bronchial trees are larger and the partial volume effect there is not important. So therefore you can really require that the value is very low to be part of the bronchial wall. However, for the peripheral segments, a higher value is needed. So that's a remark on rendering. But more important is for what purposes this is actually used, for which purposes. It's for diagnosis and operation planning in case of bronchial carcinoma, Lungenkrebs in German. Yeah, and bronchial carcinoma is a frequent disease, so if something happens in this process, that's important. And from all the articles she found and discussed in her review article, 63% related to bronchial carcinoma diagnosis and treatment planning. Another important application was follow-up after lung transplantation. Yeah? There are some severe lung diseases like fibrosis of the lung or lung emphysema. If they reach really a late stage and are extended, then people need a lung transplant to survive. Yeah? And if such a lung transplant is actually possible, you know, it's not so easy to find an appropriate donor for such a transplant, but imagine that works, then follow-up investigations are necessary in order to analyze the state of the lung and perhaps to detect early that there are some new health problems related to the lung. People have to take drugs in order to avoid that the transplant is rejected by the recipient, and so therefore their health state is improved by the transplant typically, also considerably improved, but it's still a situation that requires control. And 27% of the articles relate to this application. And another application relates to stenosis or obstructions of the bronchial wall or the trachea. And it turns out that virtual bronchoscopy here has also a higher sensitivity in detecting such problems compared to the conventional slice-based viewing that is, of course, possible as well. Yeah, the sensitivity, the specificity is not so impressive, but the sensitivity is improved. Yeah, so the measurement of the length and width of obstructions and stenosis, that is a major requirement for the functionality that you want to combine with endoscopic views. Yeah, so measurements indeed consist or could be considered as one of the core functions a virtual endoscopy system should provide. Yeah. So here we see such an obstruction. You recognize it also because it's emphasized here with an arrow, and the corresponding situation in an endoscopic view you see here. Yeah, so the bronchial tree at this point is almost collapsed. Yeah, that's from Karen Horton's overview paper. By the way, I also want to recommend this 17 minutes YouTube tutorial that explains virtual bronchoscopy quite convincingly. Yeah, measurements, I said, are important. I commented this a minute before related to bronchoscopy, but of course for endoscopy, for colonoscopy, it's also important. So here a polyp is measured, and that is indeed a large polyp, more than 5 centimeters. That's really a lot. Hopefully this really is a polyp and not already a colon cancer. And one thing I like here is that they also try to estimate a bit the uncertainty related to this measurement. Yeah, there are different sources of measurement uncertainty, but one that you can really reliably take into account is the spatial resolution of the data from which this visualization was created. Yeah, so at best you can select the right 2 voxels from which you want to compute the distance, and then the uncertainty is the size of a voxel. That is basically the diagonal of this voxel, and you have this uncertainty both for the start voxel and the end voxel, and that leads to this plus minus 1 millimeter. Yeah, so optimally such an information should be added to any measurement. And of course, this means that for a larger measurement, the relative uncertainty is lower. It's only 2%. That's not a lot. Yeah. If something measures 7 millimeters, then 7 plus minus 1 is another order of magnitude of uncertainty because the overall measurement is much smaller. Yeah, angioscopy, I mentioned this as well briefly, but want to show it here with an example, is another important application of virtual endoscopy. So here the virtual camera is moved inside vascular structures and in particular inside the coronary vessels. That was not possible, I would say, 15 years before. It started really at approximately the time when this paper from Van Ooyen and colleagues was published, because it really had to take advantage of progress that was made in CT acquisition, namely multi-slice CT data that improved the spatial resolution, and dual source CT data where you could employ two different energy levels and combine the results. That makes the discrimination of some structures easier. Multi-slice CT not only helped to improve the spatial resolution, but it also helped to accelerate the image acquisition process. And by accelerating the image acquisition process, motion artifacts could be reduced. That's clear. Yeah, if imaging is faster, then there are not so many movements going on in this shorter period of time. And the beating heart, of course, exhibits a lot of motion. Yeah, what do we see here? A slice-based view indicating camera position and orientation. An external 3D view, yeah, that shows the coronary arteries and also the specific position where the virtual camera is inside, and that is actually the inside view. Honestly, that tells you not a lot. Yeah, it only tells you a lot if you see this in the movement, if you have more context, and of course by looking carefully with respect to any abnormalities to be found at the wall. So that was really a quite nice paper. There was a lot of follow-up work, but this topic of virtual angioscopy became widespread based on this publication. Yeah, that's from the same publication. Another screenshot, again combining different views, different orthogonal views, and a related 3D view. What you see here is in reddish colors the wall of the vascular structure, and these gray colors here represent a stent. Yeah, you see the stent also here. These are the brightest structures that are almost white. Yeah, and this virtual angioscopy was carried out to understand whether the stent really remains at the position where he was placed, whether he is really fully inside the vessel wall, and was not displaced in any way. Yeah. Also, after a stent, problems could occur. There could be new stenosis can develop inside a stented region, so-called in-stent stenosis. Yeah, that's due to the interaction of this often metallic stents with the biological tissue. The material is chosen in such a way that it is quite biocompatible, as it is said. But since we are all so different, a certain material is not favorable for all patients, and you do not know this in advance. So therefore, such follow-up investigations are really important. That's an example of our work in this area. So we also looked at coronary vessels. They were segmented. We carefully determined a transfer function automatically based on a histogram of the intensities of the vascular structures and also of the stents, so that we can see simultaneously the vessel wall, but also internal structures like plugs or stents. You see an external 3D view, a slice view, and here you see the endoscopic view where the camera is inside. Yeah, so that was realized by Silvia Saalfeld, as she is called today, and Christoph Kubisch, who was also a PhD student in our group at this time. So I mentioned that we should discuss validation of virtual endoscopy. Yeah, how reliable are these views? That is important. Artifacts could occur, and that depends to a large extent from the quality of the image data. So these investigations that have been carried out in several groups led to recommendations what image acquisition parameters are needed in order to use a CT data set for virtual endoscopy. So clearly endoscopic views only show surface variation. Yeah, they cannot show bleedings, for example. That is what you would not recognize. And inflammation only in rare cases indeed leads to surface changes. Then you would observe these changes, but otherwise you would not notice this. Yeah, that is of course something that has to be stated when thinking about validation and limitations of the approach. Yeah. So where are some artifacts? Here again, I've used this important pioneering work from 2001, and they discussed artifacts in different types of virtual endoscopy. Yeah, they showed with errors what could happen. I think this is probably a problem related to the segmentation. Yeah, this is such a severe artifact that I would not believe that this is solely due to the image acquisition. Yeah, some smaller problems, yeah, like some small perturbations of the wall can be a result of the image acquisition. That is in comparison the virtual endoscopic view, fully colored, revealing texture and so on for comparison. Yeah, let me show to you two example systems. One was created directly in our group, and I mentioned this not because it was created in our group, but because we fortunately had cooperating physicians that carefully tested this development in several stages. So we had several cycles where we could improve the prototype before it was used quite extensively to treat and plan operations for more than 100 patients. The second system was also developed by one of our master students, but it was not developed in our group, but instead Christoph Roos made his master thesis at Siemens Princeton, that is the research lab of Siemens Healthcare. And yeah, he dealt primarily with colonoscopy, with fecal tagging, that is where you want to mark residual stool in order to prevent that this hampers the diagnosis too strongly. Whereas Christoph Kubisch's system was primarily developed for ENT surgeons. Yeah? ENT stands for ear, nose, and throat. Yeah? And the particular application sinus endoscopy relates to endoscopic interventions in the nasal cavities. Yeah? He applied the system also to other types of data, so there are examples of this also, but the clinical evaluation was focused on sinus surgery. Yeah? Whereas here, the clinical use case intended by Siemens was to support radiologists in order to detect polyps in the colon, as we have discussed already several times. Yeah, let me start with sinus endoscopy and let me briefly describe the medical background there. So first, of course, you have to understand the anatomy of the sinus cavities. That is one major cavity here, and then four smaller cavities. And in all of them, swellings can occur, and these swellings, yeah, may may be lost after a few days, even without any treatment or with some drug treatment. Yeah, in German we say Stirnhöhlenentzündung. That would be an example of such a swelling, causes some headache, so it's not a comfortable situation. But in most cases, no surgery is necessary. But it may happen that this is severe, it persists over many weeks, it does not respond to conventional treatment, and in these persistent cases, surgical intervention is necessary, which basically means that these swellings are removed. Yeah, they are just dragged away so that they no longer could cause problems. By the way, if this happens to a patient, there is a likelihood that's not too small that in one of the following years a similar situation occurs again. Yeah, so some persons tend to this kind of disease, which makes it necessary to plan a surgical intervention again. That is an unfortunate situation, not only because the patient has to undergo surgery again, but also because as a consequence of the first operation, several structures inside the nasal cavities that are healthy get destroyed or removed. That means in these revision surgeries, for the surgeon, it is more difficult to orient himself. Yeah, he has lost some landmarks, one could say, that are important for his orientation. I mentioned this in the last video lecture already, that this was a situation where endoscopic surgery was developed quite early. Yeah, the alternative to destroy from outside the nose and perhaps other parts of the facial anatomy in order to get access to these swellings, that is really a very bad situation for the patient, and therefore already in the 1980s, when endoscopic surgery just started, one of the first application areas was FES, and that is an abbreviation for functional endoscopic sinus surgery. Yeah, so what are the goals here in ENT surgery, or in particular in sinus surgery? Virtual endoscopy should serve for a careful preparation of these surgical interventions. This careful preparation should also include the question, is surgery really necessary, or maybe it is possible to avoid this? In this careful preparation, in particular for revision surgery, that is the situation I described when a patient has to be operated maybe several times in life, that landmarks are defined and marked that help the surgeon to rehearse and remember the patient anatomy, to not be surprised in the real surgery. Another goal, also driven by the economic goals that are so important in medicine, is to shorten interventions. Yeah, not at the sake of quality, at the expense of quality, but just to make them faster and with this also less expensive. What I would consider more of a long-term goal is to really directly use this preoperative planning information during surgery for intraoperative navigation or even robot control. Yeah, what do I mean with this? Imagine that you plan a trip with Google Maps. Yeah, you enter your target destination. You let the system compute a few paths. You select one of them. Maybe you also look at a verbal description where you have to turn around and where you have to be careful. And then you have a lot of information that prepares you to a trip. That's nice. Yeah. But if this is a long and complex trip, then you benefit, of course, a lot if you not only have some information you can remember from this planning process, but if your car navigation system really tells you where to turn to the left or to the right. And in a similar way, intraoperative navigation is possible in surgery as well, at least in selected areas where the human anatomy is not undergoing too severe changes during surgery. For example, surgery related to the skeletal anatomy, there this kind of intraoperative navigation is possible. So that's a long-term goal. Yeah, I want to show again some images from the book from Rogalla and colleagues because they also describe this application. Um, you see the nose and where the virtual endoscope should be inserted, and then you see indeed endoscopic views and corresponding CT slices. By the way, here, even if you have not done a degree in medicine, it's quite clear that this side looks different than this side. And you can imagine that the human face is quite symmetric, not only from inside, but if it's healthy, also from inside and not only from outside. And here is a swelling, yeah, this gray area, if you compare it with the black area on the other side. So here is really air inside, whereas here no air is inside. And you can imagine that such an extended swelling makes it difficult, if possible at all, to breathe through the nose. Yeah, so that is a situation where surgery is really important. So, and I suppose, although that's not clearly indicated, that this situation here corresponds to a part of this large swelling. Maybe to comment a bit more why surgical planning here is so important. Yeah, on the one hand, this type of surgery is frequently carried out. Yeah, and most of the ENT surgeons still today do this type of operation without preparation of a virtual endoscopy before. And in most cases, no severe problem would result. The surgery is a success, and major complications have not occurred. Yeah, that's the typical situation. But there are two situations, maybe one could say anatomical specialities, when this kind of surgery gets dangerous with a higher risk for complications. One is if you have to operate closely to the skull base. Yeah, the bone of the skull here outside, that is quite stable. Yeah, but inside the human body, we also have skeletal structures that separate the skull from other structures. And there the skull is thinner, and in some patients it is even thinner, it's abnormally thin. And if you come with your instruments very close to such a thin area of the skull base, you may hurt it, and your instruments move inside the brain, which they definitely should not do, and which definitely will cause problems. So in this situation, it can be dangerous. The second situation where it can be dangerous is depending on which nasal cavities are involved in the disease. The Keilbeinhöhle, that is one of them that's very deep, one cavity that is very deep. If this is involved, you operate close to the optical nerve. The optical nerve connects the eye with the visual cortex in the brain. So you can imagine that the optical nerve is essential for your viewing ability. Yeah? And not to hurt the optical nerve could be a challenge if you have to operate in the vicinity of this structure. Yeah? So these are the situations when a careful preparation is really important. A few remarks on requirements for a virtual endoscopy system for sinus surgery, and that is what we call sinus endoscopy. Of course, we should be able to process all the CT data quite fast. We need functions to support path generation. We need interaction facilities to navigate on a pre-computed path, but also in other directions of the nasal cavity. And what I mentioned as a general requirement for virtual endoscopy is important here as well. The ability to look behind the wall. That means that I can see structures outside of the current nasal cavity that I'm in by means of a transparent rendering and perhaps a careful emphasis technique outside of the structure. So path generation is something we have discussed quite quite some length in the last video lecture. I remind you again to these images from the colon from Li Chang-hong and colleagues from their virtual voyage. Yeah, basically distance field is computed that is used to determine centerline, and that is something we also did here for the nasal cavities. And like they recommended, we created this path in such a way that collisions with any nasal cavity are indeed avoided. Yeah. So we see some screenshots here from the system. To be efficient, we used an empty space skipping as an acceleration strategy to make the volume rendering really fast. We incorporated some effects, based on texture mapping actually, to resemble the wetness that we would expect in a real nasal cavity. Yeah, so this effect is seen to a different extent here on the left and on the right. Here we see a CT slice with overlaid segmented structures. Black means there is air, so that is a situation which is healthy, whereas here we see another part of the nasal cavity, so if this would be healthy, it would look black as well, but you see it's far from black, so here we have an extended swelling. Yeah. Wetness on the surfaces was simulated. The illumination was not too advanced just to cope with the real-time capabilities. Yeah, that all was realized on the graphics card, also the whole volume rendering. So here this rate traversal is a bit indicated, swelling and the wall of nasal cavity behind. Yeah. Yeah, in some stages of the project, we started with a user interface where the user had control over some parameters that control the rendering process. We started with quite simple rendering techniques, showed this to the physicians, got feedback what we can improve, and then incorporated more functions. That is a typical situation. You show something to, I think, 3 physicians, 3 different users, and each of them has some ideas of how you could provide further features, and then your user interface blows up. Yeah, if you try to satisfy everybody, you get a larger set of UI controls, which at some point is not good because it can be overwhelming, and then it's difficult for the users to cope with it. Yeah, so that became obvious after we evaluated this prototype. Yeah, here we have overdone it. We just provided too many options to specify the visual effects in detail. We improved the rendering, and we used this typical view of combination of 4 individual views, 3 orthogonal ones, and the virtual endoscopic view. The layout could also be changed in this way. So the disadvantage here is that the endoscopic view is no longer the largest view. It's no longer in the focus. So therefore, it's a good idea if both layout types are possible. We reduced the interface options here from 12 to 6. Yeah, 2 of these factors relate to these wetness effects. How far we could look into the structures could be adjusted. Yeah, so these are examples for the things that could be specified as input for the computation of a video sequence that could then be looked at with a classic functionality of a video recorder. You can play, you can go forward and backward and stop and so on. Yeah, and here you see that we are at the beginning of such a pre-recorded video. Yeah, the layout can be changed as I briefly commented, and you can make screenshots. Yeah, for documentation. That's quite important, and you can annotate the endoscopic visualizations in order to specify some landmarks or to define where you have to cut into a cavity into the wall of a cavity, which you could also use to discuss with a colleague. Yeah, so this type of surgery is carried out by an experienced physician. In German, we would say a Facharzt. Yeah, with a completed specialization in ENT surgery, and he typically is assisted by a younger surgeon who is still in his education, And it's of course a good idea if both briefly discuss in advance how the surgery is planned, so that also the younger surgeon has an understanding of what he may expect. Yeah, some more examples of using the sinus endoscopy tool. Here we see indeed these drawing functions, this annotation that is possible. Yeah, freehand drawings on top of the nasal cavities. These are indeed examples where our cooperating physicians said that that is useful, yeah, that we can in this way annotate endoscopic views. Here we have employed the same system for inner ear surgery. So you can imagine if we cooperate with ENT surgeons, they are not only specialists for the nose but also for the ear. So therefore we prototypically also used it here, and we applied it to CT thorax data and CT abdominal data in order to create endoscopic views of the bronchial tree and of the colon. Yeah, so maybe I shortly show this video here from Christoph Kubisch that he prepared in order to convey how his system works. It's not the fastest internet of the world that we see in the moment. Yeah. You see these corresponding views, yeah, how the 2D visualizations are adapted when we go further on. That is virtual colonoscopy. Yeah. Yeah, I think that gives a good impression also from this user interface here. That was in this stage, as I mentioned, a bit too complex. Yeah, yeah. So maybe that's sufficient. Back to the presentation. Yeah, clinical evaluation. I said this system has really been used. In total, a bit more than 140 surgeries were planned with the system. And not only that, it was used for the surgeons to plan their surgery, but it was also used so that the surgeons could explain to the patients what they can expect. Yeah. So there are several criteria we agreed upon for the evaluation. That is, can we recognize anatomical landmarks well enough during surgery? How accurate is the visualization? And what is the benefit for surgery planning and patient education? That is this patient consultation. Has the patient the impression that he now knows what he can expect in surgery, that he understands why this all is necessary? The evaluation was carried out by 5 physicians working at 2 different hospitals in Leipzig. So we compared also measurements that were taken on endoscopic views and on real and virtual endoscopic views. Gero Strauss was the leading physician on the Leipzig side, and in the following I briefly comment on some results that he used for his publication in the ENT Surgery journal. So the accuracy of measurements was sufficient. The deviations could be very large in a few cases, up to 11 millimeters. Typically, it was more in the region of 1 to 2 millimeters. Yeah? Compared to optic endoscopy or real endoscopy, virtual endoscopy was beneficial because the maneuverability was improved. Yeah? Certain things could be easily shown that you could not see with optical endoscopy. What the surgeons considered critical still after we reduced the user interface, that they remarked that different physicians used different settings to specify the visualization for the endoscopic views, and based on these different settings, the recognizability of landmarks, for example, was also different. Yeah, so actually it is better if there is some agreement on some default values for a diagnostic procedure and not too much variability. Yeah, if you have considerable variability, how something is carried out by different physicians, then you have also a varying quality in the results. With respect to the importance of what the physicians saw in virtual endoscopy, they often commented that what they could see is relevant. Yeah? It was not information that they do not need at all. But on the other hand, they often said by carefully looking at the CT slices, they also would infer and extract basically the same information. These are experienced physicians specialized on this area. They have seen thousands of CT data sets and sliced through them. And compared to this, of course, even 140 surgeries distributed over 5 physicians is not so much. So basically they said it's not too much additional information that we get. But, and that was the most favorable result, basically they all commented that the patient consultation was improved. The patients were convinced that this is a necessary operation. They developed more trust to the surgeons who so carefully have prepared the surgery that they could show it based on this virtual endoscopy. So that really was a benefit. Yeah. Yeah, I also want to show one further development which I think is quite important, also because it was a long-term development carried out in Vienna, and the two institutions participating here are on the one hand the VRVIS Research Center, Virtual Reality and Visualization, and the AKH in Wien, that is the Allgemeine Krankenhaus, the General Hospital, that is university level hospital, a very large one, in fact the largest Austrian hospital. Key researchers are Stefan Wolfsberger from the medical side and Katja Bühler from the computer science part. So this image, what you cannot see here in the moment because I'm in front of it, but if you look at the slides you will see it, shows you what happens here. An endoscope is inserted in the nasal areas, but then goes beyond the nasal area in the skull. So here indeed we deliberately have to create an opening in the skull to treat diseases inside the brain. Yeah? So that is endoscopic surgery carried out in cooperation by ENT surgeons and neurosurgeons. Yeah? And here is a tumor that is visible based on visualization that really makes this automatically visible. Here we have this look behind the wall effect, so we see from our current camera position behind the wall there is the pathology, and here we see it even better. That is an undistorted view, so the straight lines remain straight. I mentioned last time that we often have distorted views, fisheye views, then these lines would be curved. Yeah. So, and here we see the pathologies again a bit more clearly. STEPS was how their system was called. So the major point is that brain tumors here are accessed via the nasal cavities, and these interventions should be trained and simulated before. And as I have shown, transparency was quite important to reveal the tumor. So the last application I wanted to show is Christoph Russ' master thesis on virtual colonoscopy carried out at Siemens. And yeah, the medical problem that should be solved here is to faithfully consider the situation that the colon is not completely empty. There is residual fluid in it and also residual stool. The contrast agent has a higher density than tissue and air, and makes this visible. So the residual stool needs to be removed, not physically, but by means of image processing. Yeah? Here we see a typical histogram of the data. The air has very low values and it occurs quite frequently, so therefore it's a peak in the histogram. Then we have soft tissue structures and we have tagged fluid that has typically a higher intensity than the soft tissue structures. Yeah? So here this is recognized based on an histogram analysis and it is emphasized so that you see here would be the stool, the remaining fluid. Yeah? So that could be shown with different intensities. So these are different variants how to render this fluid inside. What they also did, by the way, was to detect polyps automatically based on curvature information. Yeah? A polyp is a structure where the approximated curvature is higher compared to the surrounding, and you can use this information in order to detect, let's say, at least candidates for polyps where the user should look into. And these results from such an image analysis are used as input for the endoscopic view and shown here. Yeah, so there was a prototype developed for clinical use. Again, it was a coordinated multiple view framework with an endoscopic view, some analytical views, namely the histogram of the data that could be used to adjust some thresholds to define the endoscopic view, and here we have the orthogonal slice views. It was also possible to create, for documentation in particular, visualizations where an endoscopic view is combined with a slice that corresponds to this position. So that is meant here with insertion of freely placeable CT slices. Yeah, let me summarize virtual endoscopy. One may say that the visualization techniques that are used for virtual endoscopy are meanwhile mature. Yeah, they work well and without errors. They are realized efficiently, so the performance is very good. And not only that the visualization is mature, also the way how virtual endoscopy is incorporated in diagnosis is understood quite well for a number of application areas. Yeah, I try to make you aware a bit for this variety of applications. With respect to image acquisition, a high spatial resolution, isotropic data, and fast image acquisition are favorable. Typically, we do not have initially isotropic data, but if the slice distance is very low, we are at least not too far from isotropic data, and often in a pre-processing step, the data set is resampled so that it is indeed isotropic when we use it for image analysis and visualization. So basically we interpolate some missing values in the Z distance to achieve an isotropic resolution. It would be even better if the data is isotropic from the beginning and no resampling would be necessary, because resampling always introduces a certain amount of error. The demonstrated value is really there for colon cancer screening and for intervention planning in different areas, for example, in case of bronchial carcinoma, lung cancer. As a major advantage of virtual endoscopy, it is possible to do it in regions not accessible by a real endoscope, and if this can provide essential diagnostic information, then this is of course quite useful. If the virtual endoscopy is carried out in order to train an endoscopic intervention, then of course that's not so useful, because at the end I can train something with my virtual endoscope what I cannot later realize with my real endoscope. Navigation is not easy, and we have a certain dependency of the quality of the data. So that was really obvious also in the medical studies that have been carried out. If the quality of the data is not really good, then the results that you may expect in terms of sensitivity and specificity for detecting some pathologies is not very good. The essential structures need to be visible and recognizable. That needs to be checked. compared to real endoscopy, virtual endoscopy increases patient comfort quite considerably, and with this also increases the acceptance of this type of screening investigation. However, CT involves radiation, and high quality CT data with a high spatial resolution involve a bit more radiation than lower quality CT data set, so that cannot be completely neglected. On the other hand, one must admit that colonoscopy as a screening measurement is recommended to be carried out every 10 years. Not every second year like in mammography, but every 10 years. So you should do it once between 55 and 65 years of age, and then again between 65 and 75 years of age. So you get it 2 times in your life, not 10 times. Yeah, and of course some pathologies are hard to see or not possible to see at all. So that's my summary. Before really coming to an end, I want to give, I call it an outlook, because some developments that have been carried out in the last years have not made it to clinical practice so far, but could have the potential to be included in clinical solutions. That is not sure yet. Yeah. So let's have a look how the future could look like. But before this, one more summary comment. Major functions of virtual endoscopy, and that's a little bit important also for the outlook, because these major functions have to be supported well also with future developments. The virtual fly-through is of course the core function of virtual endoscopy, but measurements are also important. We have seen some examples and we'll see one more. Another important function is that you can store viewpoints, you bookmark them. You can later revisit them and can use these bookmarks, for example, to carry out some screenshots. And slice views need to be incorporated as well. That means a synchronized visualization of endoscopic views, these internal views with slice views are important. Yeah, my outlook has 4 components. I want to show some examples of using illustrative visualization techniques like silhouette rendering and hatchings to emphasize features in virtual endoscopy. I also want to comment how CT data and endoscopic data may be combined for documentation. So that includes also photos that are carried out in virtual endoscopy. And the last development, so that's a paper that appeared early 2019, I will briefly comment on immersive virtual endoscopy, which basically means that we use techniques from virtual reality, head-mounted displays and the corresponding controllers in our head to really provide the feeling of flying through these internal structures. Yeah. Immersive virtual endoscopy is motivated by the core characteristics of virtual reality. You have stereo impression because 2 views are rendered for your 2 eyes. You have a wider field of view, still not as wide as you would have it in reality. That's approximately 180 degrees horizontally, but it's about 110 degrees. That's quite a lot, much more than a computer screen. This gives you the feeling of really being inside. Yeah, and I will briefly comment on this pioneering work in this area. Yeah, so that shows a little bit how virtual endoscopy, photos taken from endoscopy, also from real endoscopy, could be combined with CT data or with virtual endoscopy. The visualizations that you see here are surface visualizations created from CT data. Yeah? Some structures have been segmented. That's a tumor, for example, the yellow one. They are converted to surfaces and surface rendering is created. Yeah? And that's a virtual endoscopic views, and that is not somehow related to each other. Here we see an example of a view from virtual endoscopy combined with a photo from real endoscopy, and this view here is annotated in this way that if you select this point like a bookmark, you would see this photo. Yeah, so that is an integration of virtual endoscopy and real endoscopy. That was a prototype carried out in our spin-off company, Dornheim Medical Images. One must admit that this correspondence here was established manually. Yeah, so the physician said here, at this point, this photo belongs to. It would be even better if these correspondences could be computed automatically. Yeah, and that is something that is not completely impossible. Yeah, if you carefully analyze these structures, you may find landmarks in both views that serves to automatically find correspondence. Yeah, I said that illustrative visualization could also be used in order to visualize endoscopic views. So here you see traditional shaded views, just screenshots from virtual endoscopy. I think it's bronchoscopy. Yeah, we have these branching structures here, which you would not expect in colonoscopy. And these are structures where hatching is incorporated in order to reveal details of the surface. And here another feature line technique is incorporated. It was all developed by Kyla Won, who was a PhD student in our group. And yeah, that is still not optimized. Yeah, one could think of combining this type of visualization, for example, with this one, so that certain shading is also applied, but on the other hand, some feature lines that are detected here by a geometric analysis, so more or less feature lines represent discontinuities in visibility or discontinuities in the geometry or discontinuities in the illumination. Yeah, so you may simulate illumination here as well, and then you have different areas. Some of them are shadowed, others are not, and the border of a shadowed region would also represent a kind of feature that could be shown with feature lines. Yeah, these techniques are inspired, as you may imagine, from artists, from drawers, from people who professionally draw medical illustrations. Yeah, finally, a few comments on immersive virtual endoscopy, which is now feasible because the VR technology is widely available and it's cheap enough, and also it is not perfectly convenient, but I would say convenient enough to use it on a wider scale. With convenient enough, I mean in particular that the weight of these HMDs, that's approximately about a few hundred grams, is not too heavy. Yeah. So stereo display is available. Navigation in virtual endoscopy or in virtual reality is realized with an HMD just by moving your head. Yeah. So it depends whether we have a pre-computed path or not. If we have a pre-computed path, then the actual navigation could be something like a weighted average of the pre-computed path and the movements I carry out with changing my head orientation. Yeah? So I commented already on the wider field of view and the improved immersion as advantages of virtual reality. So Mirosini and colleagues provided such a system. By the way, the senior author of this publication is Ari Kaufmann, which I showed to you in the beginning of the last video lecture as a pioneer of virtual endoscopy, co-authoring first papers on this topic in 1995. Yeah? So meanwhile, he is 71 years old, but still is enthusiastic about making progress in virtual endoscopy. So real-time performance in immersive situations is really important. If I move my head around and the system is not able to compute fast enough, the new visualization, that's not only disturbing, but it really may cause headaches. Yeah? And yeah, we have seen that virtual endoscopy systems need a user interface where you can adjust transfer functions, rendering parameters, and other things. And these, I call them desktop features, yeah, where you have sliders, checkboxes, and interface controls like this, need to be realized, of course, also in VR. Yeah, somehow you must place them in the virtual environment so that they can be operated typically by means of a controller. Yeah, that you can grab some functions or sliders, for example. Yeah, here you see screenshots from this system. Um, Maybe I comment first on these two numbers here. Here is an 8 and here is a 5. These are numbers for bookmarks. Yeah, so it was possible to create bookmarks for later revisiting and reviewing. It was also possible to integrate CT slices. That is a core function. Yeah, and here with the controller, the user enabled an electronic biopsy, so it is somehow simulated how a biopsy would look like based on the data that's available. Yeah, some further screenshots. There is a spotlight view that focuses the illumination on a certain portion. Here the user again returns back to one viewpoint he has specified before. And here you see the measurement facilities. We discussed interaction facilities with medical visualizations and discussed measurement facilities, how to place measurement numbers and things like this. Yeah, and in a similar way, they also integrate 3D widgets here to measure the width and height of a polyp. So what are limitations of this? Yeah, I don't want to sell an immersive solution as something that only has advantages. That is not true. The spatial resolution of the HMDs is still not ideal. Yeah, it's not only the mere number of pixels which is not so high. It is the mere number of pixels in connection with a situation that your eyes are so close to it. Yeah, you are closer to the screen of an HMD than you are to your typical computer screen. And therefore you notice this limited resolution more. It is about 1,000 pixels horizontally currently. It would be nice if it would be 5,000 pixels. Yeah, then we are in this area where we would no longer notice based on the spatial resolution that our eye can have that this is indeed an image with limited spatial resolution. The viewing comfort is acceptable, I would say, but still, if you use it for a longer time, it's not perfect. Yeah, that may improve in the future. And what also is a problem, and it's not sure that this can be avoided completely in the future, what is often called cyber sickness, something that's a little bit related to motion sickness. Some people suffer from it, for example, if they sit in a car, not at the driving wheel, but maybe at the back. And if the driver is driving relatively fast and the route is curvy, yeah, then you may get a number of symptoms that cause problems to your health. Yeah? And similar problems may occur in virtual reality. There is research that indicates that certain types of navigation, for example, increase the likelihood of cyber sickness. So avoiding them, on the other hand, reduces cyber sickness. But it's not true that even with this knowledge, cyber sickness can be completely avoided for all users. Yeah, so that is a certain limitation that remains. I briefly want to acknowledge that in the preparation of this lecture, I used primarily material from 3 former bachelor and master theses here from our group. Christoph Kubisch, who now works for NVIDIA, Christoph Russ, who did his master thesis and then joined ETH in Zurich, and Arno Krüger, who was a PhD student in our group. And among the physicians that were involved, Giro Strauss from the University Hospital in Leipzig was the driving force who organized also all these evaluations that I briefly commented on. Yeah, let me also briefly comment on the list of references at the end. Dirk Bartz came up with this nice survey article, Virtual Endoscopy in Research and Clinical Practice. So he really made an attempt to consider both aspects. You see that's a quite long survey article. I want to recommend to you the paper from Li-Chang Hong and others. By the way, Dirk Bartz was also involved in this work. It was his master thesis. Yeah, the virtual voyage. I have shown several screenshots from this publication. That's really a landmark paper, quite early, 1997. I mentioned this book so often on virtual endoscopy and related 3D techniques from Rogalla and colleagues. That's a team from Berlin that appeared in Springer. And yeah, maybe I haven't highlighted it, but I should add it to my comments at least. This work from Peter van Ooyen and Oudkerk from the Netherlands, coronary fly-through or virtual angioscopy using dual source MDCT data is quite influential for the idea of using virtual endoscopy inside vascular structures and in particular inside the coronary arteries. Yeah, with this I want to thank you for your attention. I hope I could make you interested a little bit in this topic of virtual endoscopy.